Hi, it's Dr. Centeno, and thanks so much for joining me today. Got an interesting topic today on a low-income pro bono program for the ePICL procedure. And we're going to talk about that. I'll introduce that program. We'll also do what we usually do, which is a lot of Q&A. So if you've got questions about CCI, the ePICL procedure, regen med in general, just post those where you're watching in the comments, so on YouTube or Facebook, and that'll show up on my end, and I'll do my best to answer those questions. First, we're going to go over this topic, and then I'll get into Q&A. We'll spend about an hour together this morning, and hopefully you'll leave knowing a bit more than you did about all those topics, because again, we really learn here in this space by asking questions, and that's how we learn in general, right? That's how we learn in life. So same thing here. So let's get into this topic, a low-income pro bono program for the ePICL procedure. So, you know, the real PICL procedure and the ePICL has really helped hundreds of patients avoid a cervical fusion. And in this case, that's usually a C1, C2 screw fixation fusion or another type of upper cervical fusion. And it's helped them because they were very symptomatic and disabled, and they were able to get much less symptomatic and much less disabled. And many times it also serves as a springboard so that they can get into rehab and other things, whereas before they just couldn't do that. So it's been a very successful procedure to date. Now, you know, unlike what I call fake and bake PICLs, because we actually have some folks out there that have tried to do all this, the procedure is very expensive to perform, the real procedure. We've got two C-arms in the room, so we can do an AP and lateral view at all times. So that's 3D stereotactic for this particular procedure. And I also have two backups. What I mean by that is that literally both of those C-arms could fail, and we could roll in two new C-arms into that room. More likely is that one of those C-arms fails, and we have a backup C-arm that isn't used at all. It's brand new. It's been used maybe 3 or 4 times since we bought it. It is there because we have people flying in from all over the world. So if one of our C-arms goes down in the middle of a procedure, we need to be able to roll in a new one. Most hospitals don't have that ability. Our clinic does. We have an endoscope. And that endoscope we use to visualize the sterile field in the back of the throat. And we have a backup endoscope for the same reason. If that endoscope fails, we still need to be able to do the procedure because people are flying in from all over the world. So we make sure that we have this kind of redundancy built in. We've also designed now 5 generations of a 3D printed mouthpiece. This last generation, it was getting complex enough where we had to enlist a part-time biomedical engineer in order for us to get it done and get it designed, but it's made a tremendous difference in this procedure. Again, more expense. We have 3 staff in the room with a CRNA when this procedure is being performed. We have a $1 million CGMP clean room. That's unique, right? I don't know of another medical practice on earth who has this as part of their facility. And in that clean room, we can create the world's only 2 stem cell fraction bone marrow concentrate. Now, I developed that. So our Regenix sites can do that. And that's because there are 2 stem cell fractions in bone marrow aspirate, but the little kits can only get at 1, and they throw the other one away. So that's basically throwing away cells that could help a patient. So in our clean room, we can get both of those stem cell fractions out. We can produce as high a dose PRP as we want. We're not limited by the little crazy kit we bought. We can produce platelet lysate, something a kit can't produce. We can produce platelet-poor plasma. And there are 5 full-time employees that work there, including a lab manager whose job it is to keep it all sterile, to have a sterile testing program in place, to make sure all of those people doing the processing are trained, etc. We have a research team, a clinical research team, has 2 PhDs on it, 1 MD and 1 master's level member of that research team. And we have the input for that whole process, which is the bone marrow aspiration that's performed by a physician super specialist in this space, and not a little blood draw at the arm by a super cheap medical assistant. Just to give you an example there, that physician super specialist time is about 10 times as expensive as hiring an MA to do a blood draw, but it's far more sterile as the input. And one of the things that's interesting is that I saw on Reddit this week these comments that seem to be driven by the concept that in manufactured products and tech, as you scale, quality improves and price plummets. I was just listening to a podcast on the way down from the mountains here to down to the Front Range where I live full time. And that podcast was on AI. ChatGPT just came out, ChatGPT 5, sorry. And basically, they were able to reduce the cost in half and improve quality. That's pretty common. In fact, one of the crazy CCI influencers in this space is from the EV writing world. Basically, he wrote a newsletter about EV cars. And that happens in the EV space as well, right? Quality goes up, price plummets. The problem is that doesn't happen in niche areas of medicine. And so I think we've got a lot of people who don't really understand which end is up, trying to claim that what we really need is an army of doctors doing the ePICL procedure. Problem is we're never going to have that without creating a much more dangerous environment for this procedure. And the reason is that to scale in regen med, what we have seen to date is that you substantially reduce quality. So why? Well, experienced super specialists are very scarce. It's a very scarce resource. It would be like every new EV car could only be made with a rare earth element that we only had 5 kilograms of on Earth. Right? EV cars would be ridiculously expensive. And the other problem is dealing with one patient's autologous cells is expensive. And while you can, through scale, get some economies of scale there, it isn't linear at all. You can eke out maybe 20% of the cost, but the cost is the cost. Now, all of this will probably be replaced in the next 10 or 20 years by Android robotics that do all of these things. But we're not there yet. And we're not going to be there certainly in time for many of the patients that need to be helped by this procedure sooner rather than later. So a great example of how if you want to scale in regen med, the only way to do that because of those scarce resources is to reduce quality is in fact the fake and bake PICLs that I was talking about. So one way to reduce cost is that you switch from much more expensive bone marrow concentrate, just put PRP in there. The problem is that's lower quality and higher risk. I just produced 2 video shorts if you want to see why that increases risk. But it's lower quality for sure. It's not going to work as well as the bone marrow. You're going to need more procedures. Each procedure carries a certain amount of risk, so you're amplifying that risk. You're taking the blood from an arm, which is much, much less sterile than taking bone marrow concentrate in a surgical sterility scenario. Another one would be, don't use the $1 million clean room. Just get rid of it, right? Switch to a cheap bedside PRP kit. Much lower quality, much higher risk, because it's nowhere going to be as sterile as $1 million clean room. But as you can see, these are the things that happen in Regen Med, is as you scale, you reduce quality. So you certainly could just not use the $1 million clean room and switch to a little cheap PRP kit. Some of the doctors that do or claim to do a PICL, I don't believe they're actually doing a PICL, have done, of course, that. Another one is, don't spend months learning and perfecting the procedure, meaning that as I train a new doctor in our clinic on this, it takes months and months and months to train that new doctor. In fact, there was just another synchronization step where I had to synchronize all the doctors on my hands-on exam. So we're all doing the same thing. That in and of itself is going to take a week to make sure that all washes out. Or you could just, instead of that, watch 2 PICLs and call it good. Again, quality goes down. You could not spend any money on 3D printed mouthpieces that make the procedure much easier to do, much safer, and just buy something and try to use it. You could just not use the 2 different C-arms, right? Because it's very hard to find that. It's very, very expensive. And just use 1 C-arm. Again, the quality goes down. You could just not use an endoscope. Just use a tongue depressor, look back there with a little flashlight or headlamp, and stick the needle. Now, that's more dangerous. That increases risk. So again, if you want to scale Regen Med, the way it has happened so far is you reduce quality. So that's the part of this that I think most people who act as consumers, who are used to dealing with consumer products, really don't understand about Regen Med. But if you want to keep all of these things, and if you want to keep everything high quality, there is no way around it. This procedure is always going to be more expensive than other procedures that are done, like radiofrequency ablation has a certain price range that insurance companies will pay. We've seen other things maybe go down a little bit as they scaled, but because of all those quality and safety issues, this is always going to be an expensive procedure to do properly. So again, one way to make it more accessible is to compromise safety and efficacy. I won't do that. Sorry, that's not how we operate here at Centeno-Schultz. We've never done that, and we're not about to start now. The other is to do what I'm doing today, which is to create a program to allow low-income, needy patients to access the procedure. And there was 2 ways I could do that. One would be some sort of discount program on the procedure. The other one is pro bono. And I think the pro bono is going to rule the day, meaning just offer it for free to certain patients, because at the end of the day, the most needy aren't going to be able to come up with even the discounted price. So again, could make this whole thing cheaper by using PRP taken from an arm, getting rid of the clean room, hire cheaper and less qualified physicians, using a single C-arm, get rid of the endoscope, use off-the-shelf mouthpieces instead of 3D printed ones, etc. But we don't roll that way. So we're going to do this program instead. So the ePICL low-income program will be as follows. There'll be 15 slots a year that'll be designated for this purpose. We'll try to spread those out through the year as best we can. The focus of granting these pro bono slots is going to be on patients who are the most likely to respond. And the dual goal of the program is, number one, allowing access, but also using it as a way to train some of those new providers in that rigorous program so that they can get the experience they need to get good at this procedure with an experienced doctor standing right behind them. For example, you may want to pull that back, or if you go that direction, you're going to hit the bursa, or I see you're not getting great flow from that position. Here are some suggestions on how you can improve that based on the fact that I've done 2,000 of these procedures, etc. So again, the main goal of the program is to find patients who are the most likely to be helped so that this finite free resource can have the biggest societal impact, meaning I want those 15 patients or 10 patients and then 5 follow-ups, whatever that looks like, to have the highest likelihood of getting from disability to ability. And to do that, we're going to use some of the data that we're collecting to try to choose those patients who are the most likely to respond. So this will be 15 slots a year. This will be about 10 new patients and 5 follow-up patients. Obviously, initially, it's going to be all new patients. And then as time goes on, we'll reserve some slots for follow-ups and we'll reserve slots for new patients. For second and subsequent procedures, again, the focus is going to be on patients who respond the most robustly. So we could be in a situation where in a cash scenario, the patient didn't get much relief from the first one and wants to try a second. And maybe there's a reasonable shot, 60%, they might get relief with the second. But we certainly know that someone who has already had 50% relief from the first is likely to get better quicker and is certainly already past the response bar. So we're going to be focusing on those sorts of responders. Cost of the procedure will be free to the patient, but the cost of any travel or subsequent medical follow-up they need is going to be borne by that patient. So one of the things I want to say is that if someone wants to do a GoFundMe for travel who's in this program, I'll have no problem putting that on the Reddit sub that I run, ePICL, so that they can raise money. Now, I'm not going to host lots of people trying to crowdfund for ePICL procedures on the Reddit sub. But if you're in this program and you're trying to crowdsource your way to getting a ticket to Colorado, absolutely. I'm happy to try to help you because we've accepted you in the program and we want other patients have more resources who know the value of this to be able to give you money to get here after we're already in for doing the procedure for free. We'll try to spread these throughout the year. This may be determined by the training requirements, meaning we may have someone in our clinic who needs to get 3 or 4 of these under their belt. So we may push those together for that reason. But outside of that imperative, we're going to try to do these at 1 or 2 a month. And again, the focus will be on those most likely to respond who also show need. So the first process here is really the patient applies based on income, and they need to be at the U.S. poverty line or from a country where they don't have resources, meaning they're not from a wealthy family in that country, or the average salary is some fraction of the U.S. poverty line or at the U.S. poverty line or below that U.S. poverty line. So one of the things that U.S. Citizens don't realize is that at the end of the day, we're the world's richest country by far. There's not even a close second when you look at the number of people in the U.S. and the standard of living they have. Once you even go into Western Europe, the numbers come down, meaning what people make comes down. Once you go into certain parts of Western Europe, the numbers come down again. Once you go into Eastern Europe, that's basically the third world of Europe, if you will, the numbers come down again. So many Americans don't understand that there are people living in countries out there where the average US or the average wage in that country is a tiny fraction of what it is in the United States. We all know that because we see, for instance, We know that Mexico has a lower standard of living, for example, but what they don't, most US citizens don't understand is that countries like Italy, for example, have a much lower average income, or countries that you would think that wouldn't have that issue, like Spain, have a lower average income. So we will look at all those different things as well. Once the patient's through that income verification step, then they can go through our usual candidacy process. That's going to be free to them. And then once they get past that, where we think they're a good candidate, they can get a telemedicine. That's going to be free to them. And we're going to be prioritizing those patients who are the most likely to respond. Now, if we have too many applicants that are all qualified, then I'm going to crowdsource it. Then I'm going to put those applications in a blinded fashion so no one can identify these patients. I'll probably, for example, have AI rewrite their symptom matrix so that no one can even identify them on social media. And then I'm going to crowdfund it. I'm going to put that on one of two different groups. That's either going to be on the Facebook group run by Dan Semrad and his colleagues. That's the PICL Facebook group. And I'll also put it on the Reddit sub, RPICL. And we're going to have people vote on both of those. And then that's how we will determine who gets the slot. So the goal there is to, obviously, maybe we won't need to do that. Maybe we will have maybe we'll only have 15 patients a year. I suspect we'll have more, in which case we're going to crowdsource those final decisions, which is really going to be kind of random, right? At the end of the day, it's another way to do a random choice. So the dual goal of the program is accessibility and physician education, and going to solve the issue of physicians who are trying to do this having no education by actually educating qualified people on, or qualified physicians on this procedure, how to do it properly, what not to do, how to keep patients safe, etc. That program is going to involve didactic training, hands-on experience, and then basically having a master physician offering direct supervision. This is what you do. This is how you do it. I wouldn't do that. You may want to change this. You're under injecting that ligament. Based on your spread pattern right now, it looks like that's a complex alar where you're going to have to hit several bands. Or based on your spread pattern right now, you really need to hit the accessory ligament. Here's how you do that. That doesn't look like the accessory ligament. It's over there. So that's the kind of feedback that these physicians will get, so that they end up being masters at this themselves rather than, hunt and peck cowboys. And so all of these are going to use less experienced physicians being directed by more experienced physicians, and nobody who is not already a regen med super specialist is going to touch one of these patients. So every single one of these physicians who will be trained is going to be a rock star in and of their own right, in the other things that they do, and ready to get trained. Meaning we're not taking family doctors off the street, burnt out ER doctors, burnt out surgeons, etc. We're taking qualified regen med super specialists who are already at a very high level and then training those. So another thing I want to bring up, if you've already had one ePICL procedure, you're not eligible for this program for obvious reasons. So I want to make sure I bring that up right now. So in summary, the goal will be to start this program, give or take, in the next month. I've sent out the instructions to my staff. I can't guarantee it gets started in the next 30 days. My staff is busy with a lot of things, as you might imagine. I keep them busy with a lot of things, but that's the goal. And hopefully this program allows for better access to ePICL and will facilitate getting more physicians trained. So I think that's it. Let me stop that share. And we will go to questions. Before I get into questions, do me a favor, give me a like, just because we want more patients to find this. And that's the only way we can do that with Facebook and YouTube algorithms. Cassian, given the glymphatic system depends on proper head position in sleep, what are your thoughts with regard to CCI patients? Could this be a factor in brain fog? Let me adjust my camera here, guys. This one tends to move a little bit over time. It's possible. Again, I think this is one of those things that we won't really know the answer to for quite some time, but it's possible. I think what we need to be careful about with all of these things is hypotheses multiplied by hypotheses multiplied by hypotheses. So for example, we have a hypothesis that the glymphatic system can be involved in brain fog. That's not actually proven at this point. That's a hypothesis. Now we're multiplying that hypothesis by whether or not proper head position could have something to do with glymphatic drainage enough where it could affect cognition. And then we're multiplying that hypothesis again by the concept that that is going to be different in CCI patients enough where it can affect brain fog. So be a little careful where we're getting into hypotheses multiplied by hypotheses multiplied by hypotheses. Jessica, some people describe after PICL procedure a sound of gritty or crunching or popping noise. Just wondering what this could be. Yeah, Jessica, I've seen that for years and years and years with regard to any ligament tightening procedure. And what I mean by that is that if you think about it, if you have a joint that's highly unstable, you don't really get a lot of noise out of it. You might every once in a while hear a clunk, but for the most part, you just get a lot of shifting and then the joint swells. If you were to tighten that joint down, you can then start to get more noises out of it, right? Because you're now having more high-pitched noises coming from small amount of motions. So that's a pretty common one with any kind of procedure whose job it is to tighten down ligaments, meaning that over time, as that joint tightens, you're going to get more sound out of it than you had before when it was super loose. Amanda, I feel like my entire body is leaning to one side. Would this be an example of the riding reflex, such as a right-sided head tilt, torn glute, hamstring, posterior tibialis tendonitis in my ankle, all one side of the body, possibly downstream mechanical effect? Yeah, so Amanda, I think what you're describing is that at the end of the day, there's a powerful system in our upper cervical spine whose job it is to keep us positioned correctly, right? That's also part of what happens in the vestibular system, and the eyes are involved in that, but there's also input that comes in from the upper neck. So when that's off, your whole body can be thrown off, and you bring up the riding reflex, right? So if you think this is straight up and down because your upper neck is messed up, then you're going to right your visual field to horizontal, and that's going to throw other things off. So that certainly could be causing what you describe. Jessica, some people describe her, oh, I got that one already. That one came in twice. Sorry about that. MW and GW. Why is industry so lacking in neck specialists or specialists deficient in innovative procedures? Yeah, I think there's a couple different levels we're talking about there, right? The first would be that you would have to have a doctor that knows something about regenerative medicine. Now, the good news is there's a lot of weekend courses. So we have we have a chunk of doctors now, not a lot compared to the total number of doctors, but a chunk that understand something about regenerative medicine, but basically they took a weekend course and they don't know a lot. Then we've got, out of that percentage of doctors, the percentage of doctors who have actually been trained to do any kind of spine work, smaller amount. That includes low-level spine work like, hunt and peck prolotherapy that's blind. Then we've got the number of doctors who can do image-guided procedures, who also know something about regenerative medicine. Now we got a smaller group. Then we've got the doctors who can do imaging guidance with contrast confirmation and do more advanced spine, who know something about regenerative medicine. Smaller group. Then we've got the doctors who can do any kind of upper cervical work and meet the past criteria, much smaller group. And then we've got the number of doctors who actually do a lot of upper cervical work. And now we're down to the number of doctors worldwide I can count on two hands. So it's basically just a complex Venn diagram, right? The total number of physicians, then it gets smaller and smaller and smaller and smaller and smaller, which is why the concept of, well, we're just going to train a bunch of docs to do PICL is ridiculous. There aren't enough doctors out there who could even do this procedure safely, who could be trained, i.e. who wouldn't kill someone once a year, to move that number. And that's why I laugh at the CCI influencers, like the electric vehicles guy, because what they don't get or understand is that this isn't consumer products. Now, again, 20 years from now, that may change. I may not be around 20 years from now to see it, but I suspect we'll have android robots performing these procedures. I suspect that AI will drive those. And I suspect that at that point, there will be scaling effects. But we ain't there yet, and we're not close to it for things like this. It's been advanced by Sherry Scott. I am so excited about this news. How do you apply to the program? Yeah, Sherry, so we are going to come up with that over the next month or so. I tasked my staff yesterday, kind of gave them a detailed email of what I want them to do. Again, realize if you've had a past PICL procedure, you don't qualify. So this would be only patients who are living at or below the U.S. poverty line who would qualify this if you're a U.S. or for this if you're a U.S. patient. You also then have to be a type of patient who we think clearly has craniocervical instability due to a known cause and is highly likely to respond to this procedure. Greg, thanks for taking time today to help form all this in this long path. Thank you, Greg. Yeah, this has been obviously a decade of my life perfecting this procedure. Cynthia, has your research indicated how common CCI is in the population? No, Cynthia, that's a hard one, right? I don't know that anyone knows that question, meaning even if you tried to do that, you could only really pick out CCI that results in immediate surgery. So for example, if we had a socialized healthcare system, let's say Norway, and we go into Norway, what we should be able to see in their health data is, maybe people who get car crashes who then end up getting an upper cervical fusion. That would be pretty easy to do. What we would lose track of is people who get in car crashes and 3 or 4 or 5 years later get an upper cervical fusion, or someone never got in a car crash at all. They just had hypermobility and they got a fusion. The problem is that it would be impossible in that kind of patient population to get an accurate read. You can maybe get an estimate to say that of a certain number of humans, this generates a certain number of fusions. But even that's not accurate, right? Because we know that there's probably a lot of humans out there that aren't getting diagnosed with anything, who aren't getting those fusions. So as you can see, this becomes more hard to do when we're talking about elective procedures rather than emergent procedures. And we're always going to have a lot of patients out there who never get diagnosed. And I know that PICL patients in the PICL community know that one by heart, right? You've gone from specialist to specialist to specialist like a pinball and a pinball machine. And none of those specialists told you what's wrong until you happen to hit the one guy who seemed to know about this. So just never going to be able to get that accurate number until we educate the entire medical care system, which may not happen in my remaining lifetime. It's been advanced by Harry Winston. What do you expect to be waiting time for a PICL procedure as part of this great new program? I'm not quite sure what you mean there, Harry. If you mean, will it affect the existing waiting time for an ePICL procedure? It shouldn't, because these will be all newer physicians who are performing these. As far as the waiting time for this, for 15 slots per year, my guess is it won't be super long, but it could certainly get longer the more people who apply. Kat, I received an email from your office in January saying that you had changed your qualification requirements. I'm now allowed to come and get a PICL injection. I've been emailing your office since, getting this email saying I really want to come, but I need an updated report to add to my insurance file. You originally gave me a report saying I do not qualify. I recognize my insurance will overcompensate, but they also heavily penalize me for doing things that are not doctor recommended. Having a hard time conceptualizing this one. So probably what you're discussing here, Kat, is that about 1.5 years, 2 years ago, somewhere in there, we decided to allow patients who had gotten a surgical fusion recommendation from one of the surgeons that do this all day, every day. That's about 5 worldwide surgeons who didn't meet our specific criteria to go forward with the PICL. So I think that's the category you're talking about. I think what you're saying in that you need an updated report maybe is that you need to get on another telemedicine with one of our doctors in the CCI practice at CSC who can maybe update that report and say, yes, for the following reasons, this person is now a candidate. So if you want to put all that in an email, I'm going to put my email in the comments here. This is the email that goes directly to my desk. Let me make sure I got it right. And that'll go into the comments. So why don't you send me an email directly, and from that, describe what it is you're experiencing here. And then I can talk to my staff about this this issue and try to get things moving forward for you. Edgar, how many PICLs would be required for it not to be considered experimental? It's my first with Dr. Schultz 5 days ago, and I'm still sore with low pain. Your clinic staff are excellent in Colorado. Oh, Edgar, I don't think in the next 10 years this is going to change from experimental to standard of care. For example, PRP in a knee now has more total data than corticosteroids in the knee, more published research, better published research, and that's still considered experimental. And that, there have been probably, I'm going to guesstimate here, but hundreds of thousands of patients a year now getting PRP in their knee. And that will probably switch from experimental to not experimental sometime here in the next couple of years, I'm guessing, just for that one clinical indication for PRP. So I think this is going to be an experimental procedure for CCI for a very long time. I'll probably be a very old man, no longer doing stuff like this, hopefully still with it by that time, before that happens. But it's certainly a long-term goal, meaning that that's a big rock to push uphill. I've pushed it uphill with regenerative medicine in general with Regenix. We have 4,000 US companies now that cover these procedures, including PICL. So I've pushed that rock uphill probably farther than any other human on earth, and I'll continue to push it uphill. Happy one. I had lower PRP quality about 15 times. It may have helped some, but it wasn't addressing CCI and upper ligaments. Yeah, so that's a common issue, right? There's a bunch of different things to unpack here. One is, what was the PRP quality? That can be important for sure. And then the second thing is, where was it injected? Was it actually injected into the ligaments that are the problem, or the other structures that are the problem? And sounds like that didn't happen. And that makes sense. That happens all the time with our patients. And one of the take-home messages for patients there is don't waste lots of money getting 10 Prolo visits or 7 or 8 PRP visits if you've got the type of craniocervical instability that isn't going to respond to these posterior injections, and that is critical. So if you've got anything but a 3A type of CCI, you're wasting your money in general by doing that. And I've seen this happen a lot where patients waste lots of money on these procedures that aren't going to work or less likely to work, and then they don't have any capital left to do things that probably will work. Rishi, is Algocels authorized to treat upper trapezius tear? Sure. I mean, that's something you may want to discuss with them directly, but that's a relatively low risk procedure. So they would be certainly authorized to do it. As to whether or not they really feel like that's in their wheelhouse, it should be, but that's something you probably want to discuss with those guys. Are you aware if the faker bakers tend to publish their experience with their methods? It would be nice to show just how much your methods experience safety and efficacy. Oh, I think the fakers and bakers don't have the infrastructure to publish anything at the end of the day. That's why they're fakers and bakers, meaning that, you know, we put together this procedure. We have a research infrastructure that costs millions of dollars to put into place, so we can do things like this. For instance, we've got a registry where we can collect this data. We've got 4 people on that research team who can parse all the information. We've got a fellow who constantly comes through and who's an MD who can assist us and get a physician's eyes on all of this. So I doubt we're going to see that anytime soon. Edgar, can you talk about which patients are the most likely to respond to ePICLs? Sure. So this is going to be number one. Priority would be given to patients who are within the first 12 to 18 months of a car crash who clearly have craniocervical instability. So they're typical patients. They have headaches, dizziness, and balance as their main symptoms, and then they may have other things. Compare and contrast that to someone who's had mystery symptoms du jour for 20 years. They've got 6 other diagnoses. 4 of those are alternative healthcare diagnoses that aren't generally recognized by the medical community. And their symptoms generally don't match CCI. Nothing changes when they move their head and neck around. And it's a guess as to whether or not they have CCI to begin with, meaning their imaging may show it, but we don't know if it's symptomatic. And certainly a guess that they're going to respond to this procedure. Happy first PICL July 2025 with Dr. Schultz, 75% better. Wonderful to hear. Scheduled for a second in a month. Unfortunately, I have to borrow money from family and get second PICL. Gotcha. Well, I'm so glad, happy that you are doing so much better after the first. Great to hear that your experience with what we call the CCI practice within Centeno-Schultz has been so positive. Need to get functioning up to make a living again. Yep, that is the seminal problem of a good chunk of CCI patients. Now we have CCI patients who are still working and they're kind of, meeting or kind of eking out an existence, and they create a box, a functional box. But we certainly have CCI patients who aren't working at all. It's been advanced by Sherry Scott. This is such incredible news. I think I got that one already. So can we assume that the ePICL procedure is only done at Centeno-Schultz Clinic? Yeah, I don't think I did get this one. So yes, the ePICL for the time being will only be Centeno-Schultz Clinic. We're training a Florida clinic right now as we speak. So at some point here in the next year or two, we will announce another site that'll be closer to the East Coast where this will be done. But that training is going to take many, many months. It's not just come and watch 2 PICLs and go home and try to stick needles and hope it works, which is kind of what's happened to date. So we're not doing it that way. We're going to do it the Centeno-Schultz way, which is everything is done by the book, all I's dotted, all T's crossed. And we can make sure that the people that leave our clinic that claim to do an ePICL are actually doing an ePICL and can produce similar results to what we can produce at Centeno-Schultz. Is this only for Dr. Centeno, or it can be for Dr. Schultz, local Denver? You happy you wouldn't be a candidate for this program since you've already had one ePICL. It would be only for new ePICL patients, but it won't really matter, be doctor agnostic, right? At the end of the day, once you're in the program, you would get accepted for an ePICL procedure. A less experienced doctor would be doing the procedure with direct supervision from a more experienced doctor. So that might be, for instance, Dr. Centeno or Dr. Schultz supervising Dr. whomever in doing that procedure. Karen, how many of your patients have multi-level cervical disc herniations with accompanying moderate upper cervical ligament laxity, and how does the presentation affect the diagnostic process in terms of the pain-generating tissues when a patient is trying to determine treatment approaches, ePICL, ECDF, habit correction, corrective exercise, patient's chief complaint is chronic neck pain? Yeah, so if the chief complaint is chronic neck pain, it's unlikely that that's a CCI patient, right? At the end of the day, CCI patients have certain parts and pieces that make them CCI patients, usually in the symptom complex. So for example, one of those would be headaches and dizziness. That might now push us more towards craniocervical instability or thinking about that. As far as how many of our existing CCI patients that are confirmed have multi-level mid to lower cervical disc bulges, I would say quite a few, probably 1 in 3 to 1 in 4. And that creates sometimes another locus of treatment, meaning that in many of those patients, we're treating the upper cervical spine and the lower cervical spine at the same time. And there's probably symptoms being caused by both. Now, we certainly have patients with lower cervical disc bulges where those are asymptomatic and the symptoms are coming from up here. That makes it easier. And we have patients that are the opposite, right? We look at them and we're like, we think all the symptoms are coming from down here, not up there. And that's where you should focus your attention. Snowmass, does CSC or Regenix treat all body parts injuries where ligaments and muscles are involved? Are there any specific doctors specialized in certain areas? CSC treats everything. Now we have within CSC a CCI practice. So that's going to be myself, Dr. Schultz, Dr. Pitts, and now Dr. Merkel. So those 4 CSC doctors focus on CCI. There is no one else in the Regenix network that focuses on CCI. But the Regenix network, like CSC, treats the whole body as well. So Regenix doctors treat knees, shoulders, ankles, low backs, the cervical spine, except for the upper cervical spine, etc., with CSC being focused on that upper cervical spine as well. Curious to know any names you can give about the physicians you think are qualified or plan to be training for the PICL. No, I'm not going to go there, Mark. I can tell you there is no physician practicing out there who I would refer my brother, my sister, or my significant friends to for a PICL, meaning I would not send a friend or a family member to any of these fake and bake clinics at all, just because I know what it takes to do this procedure. I know how it can go seriously wrong very, very, very quickly for that patient. As far as the Florida clinic we're training right now, I'm not going to give any information on them until they've passed the training, mostly because I don't want to put them in that position, right? At the end of the day, let's say they don't pass the training. Let's say they're not dedicated enough to really pass all of the tests that I'm going to put in front of them. I don't want to embarrass them at all. So you'll only hear about them when they've passed all of those tests at the various levels. The first one's going to be they've passed the upper cervical facet injection tests, and then you'll hear about them at that point, and then hopefully we can get them to that next level up. Bonnie, where can I apply for low-income PICL in Boulder and meet the guidelines you outlined? Yeah, Bonnie, again, if you've had a prior PICL procedure, you're not a candidate for this procedure. If you've never had a PICL procedure, then you could theoretically be a candidate for this. And again, we're going to prioritize those patients who are the most likely to get a positive result. And so realize that for many of our patients, probably 60% will fall out there. But if you're interested, just stay tuned. A great way to stay tuned is to join the Reddit PICL or Dan Semrad's PICL Facebook group on Facebook. I run the Reddit RPICL, and Dan, who is just a third party. I'm not part of the Facebook group at all. Dan runs that Facebook group on PICL. So I expect that you'll hear more at both of those sites as it is revealed. Zigzag, do you think it's possible that stability provided by calcified styloids can hide anterior C0, C2 instability? Yeah, realize that calcified styloids are a little different than the average bone spur. I think what you're referring to is that a joint, in order to stabilize itself, will grow bone spurs. Now, the good news about growing bone spurs in a joint is that you end up with a more stable joint. The bad news is that those bone spurs can cause other problems. They can decrease range of motion. They can press on other tissues or nerves, etc. This is a little bit different, right? When you have calcified styloids, you're not getting a lot of advantage out of that. And what's happening there is that the ligament, the sciathyoid ligament that connects to the styloid process, is getting overloaded, and in older people, it's creating bone. So I don't know that there's a lot of positive advantage on stability there. Maybe at the margins, but not in the same way you get positive advantages from bone spurs stabilizing a knee joint, for example. Wonderful vision, Dr. C. I've recently watched your brilliant interview with Dr. Henderson. Has there been any correspondence on your subtypes? Not yet. Anoxia, we're basically trying to complete our paper on our side. And then what I had discussed with him is as soon as that's done, I'll be sending that paper to him for review. And that's when we'll start kind of corresponding and all of that. But thank you for asking. Natasha, I felt taller after the car crash. Is this possible? Yeah, Natasha, if you lose your lordosis, right, that does gain you a little bit of height. Now, not a lot. Maybe most people like a centimeter, maybe 2 if you're really tall. But realize at the end of the day that that's not positive, that when you lose that curve. So I guess it's theoretically possible that a lost curve can gain height because it's going from this to that. But it's not one I hear a lot. So, so maybe there's something else going on there. Pia, can you say something about many times the ligament typically is injected per a certain length? Not sure what you mean there, Pia, meaning that, we inject ligaments with direct visualization. So we can see if the stuff we're injecting is going into the ligament. And if it is, then it might just be one time. If it's not, we might need to inject it several times, but there's a fixed outcome there. And that is that we need to see what it is we're injecting cover the entire ligament. And sometimes that's once, sometimes that's twice, sometimes that's 3 times. It really depends on the feedback we're getting from the visualization device. Pia, how much do you see clinically that injection of shoulders can influence neck stability in general? I think there's an interplay for sure there between the neck and the shoulders. It's one of the reasons why I always check for sternoclavicular joint, AC joint, and glenohumeral joint stability. And we also check the muscles that go between the two, because I do think they play off of each other. I think if you're unstable in the cervical spine, you can certainly have that be made worse by instability in the shoulder girdle complex and vice versa. So I frequently, for example, treat those joints when we're treating the neck because I think they're directly talking back to each other. Cynthia, should the patient reduce any PT activity during the bobble stage? My daughter is week 7. She reports increased instability feeling at this point. I know it's likely temporary. Only if it's causing aggravation. You're describing what I call the donut hole, right? You start out with any ligament procedure where the ligament is swollen and things feel much tighter and more stable. Then as that swelling goes away, you get into the more unstable period. And then as the ligament starts to remodel and rebuild, it feels better. So I think the answer is, like anything else, it's all to patient tolerance. Threading that needle in rehab between enough to get stronger, but not enough to cause a substantial flare-up, which is a net negative. Lindsay, were the doctors you were training going to practice ePICLs? Are they going to work at your location or other parts of the country or world? Yeah, Lindsay, right now, I think, as I said, we're going to be training a Florida clinic. They'll come to our clinic for the training. Then they'll go back to their clinic where they will practice. So at the end of the day, they'll go back to wherever they're from. Obviously, we'll continue to train our own providers. That's the easiest thing to do because they're all right there. And again, like I said, training one of our own providers takes months. And so, that's why training other providers in this is challenging. And we don't allow our own providers to come in and watch 2 procedures and call it good. That would be incredibly irresponsible of us. Brittany, I want to ask, is there ever an indication for Prolo or tetradental sulfate for those with EDS tightened ligaments? Prolo for sure, Brittany. We use Prolo quite a bit. As far as using, basically what you're describing is sclerosant agents. Sclerosant agents are pretty rough on ligaments. So the sclerosing agent, I believe you're describing, is usually used to sclerose varicose veins. So we don't really use sclerosing agents at all. Now that's an old Prolo concept, right? Going back to the early days of Prolo, if hypertonic dextrose didn't work, you threw in some P2G, which is even worse than what you're describing, or maybe another sclerosing agent, or even pumice for the old-timey Prolo guys. Now, with PRP and bone marrow, that's kind of gone away, right? There's no reason to do that anymore. If Prolo is not working, you switch to another orthobiologic like PRP, like bone marrow concentrate. The biggest downside with the harder sclerosants is if you inject them into nerves or where they're not supposed to be, they're going to cause some substantial mayhem and injury. So it doesn't make sense anymore to do that. It makes more sense to just switch to an autologous orthobiologic that's stronger than Prolo. HFBHJ on Reddit, physicians like Dr. Williams, Dr. Patel, and Dr. Silver mentioned where patients have gotten their upper neck joints treated. Assuming you're training them for PICL. No, not training any of those physicians for PICL at this time. Again, we don't recommend even upper cervical injections be done outside of Colorado. So I can't recommend Dr. Williams, Dr. Patel, or Dr. Silva for even 0-1 or 1-2 facet injections, because none of those doctors has been trained in my clinic to do those upper cervical injections. Now, if those doctors want to come and spend the time it would take to learn how to do those at our clinic, I think I'd be open to training them in 1-2s and 0-1s. Not Dr. Patel, because he wasn't one of our fellows, but Dr. Williams and Dr. Silva. As far as doing PICL, I don't anticipate on training any specific physicians, and being one of our fellows isn't really the main qualification. The main qualification is that we've got a clinic where the doctor is properly trained, knows their way around regen med. That doctor is agreeing to a kill switch type scenario, meaning if we don't certify them as being able to do this, they don't do this. So at the end of the day, none of those doctors are on the list to get trained at this point. And the Florida clinic does not contain one of those 3 doctors. Snowmass, do you see in 10, 20 years, CCI will be more accepting condition in the medical community with time of diagnosis? I do, but not because doctors will be more accepting of it. I think that we will have far fewer doctors in 20 years' time. And what I mean by that is that most of the diagnosing at that point will be done by AI. And if we're talking about the 20-year time frame, most of the treatment will be done by AI and Android robotics. So I think we will see in that type of world early detection of craniocervical instability, early treatment of craniocervical instability. But that's still quite a ways out. And I think we'll probably worldwide have a need for some tiny fraction of the doctors we have right now. Because of that, meaning I think AI will do diagnosis far better than any human physician could or ever hope to. And that AI will probably live on your phone and tell you what's wrong before anyone else knows. Parallel, follow up on Lindsay's question above, are you able to discuss potential future locations, newly trained PICLs? No, not at all. Listen, guys, for each PICL site, it's going to take a year or more to bring them on board, just given the limitations that doctors have in how much time they can take off from what it is they do to train. So I don't see an explosion of PICL types anytime soon. I think we'll probably have the Florida clinic on board by end of 26, something like that. So just realize that this is not some sort of speedy thing, and it would be irresponsible of me to make it a speedy thing. So for example, I was asked at one point by one of the crazy fake and bake people out there whether I would teach a weekend course on this. Now, that is one of the more irresponsible things I've ever heard a physician tell me or ask me, right? This is certainly not something that can be taught in a weekend course. And if you taught it in a weekend course, we'd have 3 or 4 dead people by 2 or 3 years in, meaning the procedure is that precise and difficult that if we taught a weekend course on this and just allowed a lot of doctors to start doing this who didn't have the equipment, didn't have the base training, didn't put the time into it, wouldn't put the effort into it, who we couldn't stop if they were doing a bad job, we'd have dead people showing up from the PICL procedure. So no, it's not ever going to be a weekend course. And you can hopefully see how ridiculous that would be with a procedure this complex. Pia, in cases of maybe prolotherapy, helping a patient more than stem cells or PRP, would it be fair to think those patients have less metabolic healing potential and therefore may respond more to non-biological interventions like Prolon? Maybe that's prolotherapy. I'm thinking that's prolotherapy. Prolon is a fasting kit, medical fasting kit. So I'm pretty sure you're talking about prolotherapy. No, Pia, what we've seen, for example, in many hypermobile patients is that the bone marrow construct works the best, then prolo, then PRP. That's different from normal ligament patients, for example, where it's BMC works the best, PRP, and then prolo. So if someone is getting more help from prolo than, let's say, PRP, that could just mean that they have a certain genetic makeup that allows pro-inflammatory treatments to work better, for example. Snowmass, how many hydrodissections are needed on average, and how does it take to see the effect after one? That depends on the complexity of what it is we're treating, but usually hydrodissections work within one treatment and usually the 4 to 6 week time frame. Ezra, can you keep up the great work, Dr. Centeno? You're an inspiration. Well, thank you, Ezra, for your kind words. This is my email address for that one patient that was, I wanted to email me so I could try to help them get unstuck. What am I drinking today? God, I should get a paid promotion for this or something, right? 7 teas, wildflower honey matcha. One of my favorites, hard to find, but I'm a big matcha fan, and I love these. I love this company. It's just a little bit sweet, not a ton of sugar, so that's what I'm drinking. But I don't get a paid promotion, trust me. Keep up the great work. Gotcha. Thank you. Amanda, how common is Boehner syndrome and what imaging is used for diagnosing it? Is more prevalent in patients who have punticulus? So let's see, very uncommon. And as far as imaging is concerned, you would need movement-based imaging with a CTA. So you need a CT angiogram with movement to really get a good sense of what's going on. As far as is it more prevalent in punticulus patients, so that everyone understands what you're asking, there's just a genetic variant where some people have a little bony arch that goes over the vertebral artery. And at the end of the day, we don't think that bony arch makes a big difference for them with any of these things. Now, is it possible that it could have some predictive capability on the margins? It's certainly possible, but my sense would be that the answer to your question is maybe, but we probably don't have enough research yet to draw that conclusion. Is there a way to prevent CCI if you have hypermobility, preventing laxity posteriorly through PRP? I would say don't do this all day. I would say that to everybody, right? This is a phone. Don't do this all day. Meaning that at the end of the day, I think we're seeing a explosion in the number of neck cases, of which CCI is a very small subset, because people do this all day. And that's a new thing. Evolutionarily, that's a new thing. If you go back even 100 or 150 years, people didn't do this all day. Maybe at night, a woman would crochet, or a man might be working on something in the 1850s, but they spent all day upright doing things just to be able to function. And I think a lot of modern humans don't realize what it took to run even a Victorian house. We used to have a Victorian house. We got rid of it when the kids grew up because it was too big. But man, what it took to run that house just to get the heat going in the morning when it was built in 1890 was absurd, right? Someone had to wake up super early in the morning. They had to go to each and every coal burning fireplace or stove in the house, put new coal in it, probably clean out the other junk that was in there, light it, get it going. Even cooking breakfast in the morning would have taken an hour or more just to get the stove hot enough to cook breakfast. So I think we really don't understand the amount of work our ancestors did. So if you want to prevent CCI and other neck issues, don't do this all day. And realize that the more you do that, the more screwed up you're going to get. Is it true that most of ligament strength comes from attached point onto bone? I think what you're asking is, can ligament strength be due to how well it adheres to bone? Certainly that's one part of a ligament strength, but it doesn't really describe all the ligament strength, meaning ligaments are specifically designed for the forces that they undergo. And there's one metric, which would be strength to failure, but those tests aren't all that accurate, meaning they're not real world. So if I want to try to test a ligament in strength to failure, I have to take a cadaver, I have to denude the cadaver of everything else so I can see that only one ligament, meaning I'm taking out structures that prevent that ligament from failing. And since I have a cadaver who doesn't have active muscle tone, I can't measure the real world tensile strength of that ligament, i.e. how would it perform in a real world setting, because that cadaver doesn't have an active nervous system and doesn't have active muscle tone. So just take everything you read about how strong ligaments are with a huge grain of salt, because at the end of the day, we're really guessing. Those are more what I call WAGs. You can guess what the WA stands for, guesses. They're educated WAGs, meaning that, yeah, the transverse ligament's probably stronger than the alar ligament, for example, or the calcaneofibular ligament in the ankle. But in the real world, what does that mean? It probably means that it's harder to pith someone. That makes sense. But my guess is, under the right circumstances, those other ligaments are equally as strong because of their active stability systems that we can't measure in cadaver studies. Casey, can you tell us what Florida clinic you're training? Nope, can't do that for the other reasons I discussed. Can a long-term trauma from chiro manipulation lower results from PICL? I think what you're asking, and maybe I'm wrong, is if your problem started with a chiropractic manipulation, and that's what caused the CCI, are you going to respond more poorly? No, we see a chunk of our CCI patients who have that issue. Let's see. And now I'm at about an hour and 12 minutes, so I'm going to just start picking out some of the more interesting questions. Here, Manfredi, do you still offer online consultation? We do. We do this all day, every day. So just go on the Centeno-Schultz website under our CCI page, and it'll tell you what you need there. Amen. I try to go to the gym 4 times a week, and I use only supported machine, supported neck, because it's beneficial for CCI AAI. Amen. For some patients, for some AAI patients, at a small subset of the patients that we see, that might be very helpful to get core strength that way. For most of our CCI patients, that would piss things off. And at the end of the day, that would probably make them a lot worse. So again, realize that when you go online and you hear all these other CCI patients, they're all in different categories. They all have different causes. They all have different levels of nerve irritation or nerve damage. They all have different levels of movement in certain areas. They all have other issues that are also causing symptoms. So trying to go on there for advice is going to be difficult, because at the end of the day, you may be talking to a person that bears no resemblance to the kind of CCI that you have. But if you feel like that's helping, I'd say go for it. Do you think some patients need ON decompression surgery? Sure. There's certainly some patients out there that would need occipital nerve decompression surgery that can't be treated non-surgically. I think the big downside for occipital nerve decompression surgery is just going to be the fact that you have to destroy some things to do it. If my IGV is compressed severely for years, will it open up after treating the source issue, or does it need a stent? Amen. Probably less than 1 in 1,000 of the patients that I talk to would ever need a stent. And IGV compression is a normal part of daily life. So be very careful with that, meaning that in CCI patients, we see intermittent IJV compression, which can lead to things like pressure headaches, tinnitus, and other symptoms. Having said that, in those patients, if we fix the instability, then that's usually no longer an issue. But in that patient population, probably only 1 in 1,000 would ever need a stent. So not something I would recommend for the vast majority of patients I speak to. Prolo teacher suggests only the ligament attachments need to be injected. Yeah, I don't think that's true at all, Casey. Meaning at the end of the day, that came from the idea of blind 1950s and 1940s prolotherapy, right? Meaning you couldn't inject in the middle of a ligament in those days. All you could do was bony landmarks. So you're talking to an old-timey prolo guy who's back in the 1950s, thought process. These days, now that we can see ligaments, whether it's under fluoro with contrast or with ultrasound, in situations where we can see them with ultrasound, you can easily inject the whole ligament. But that's a holdback from 1950s Prolo, when, with palpation guidance, meaning blind, you could only hit a bony landmark. So that's where that came from. That stuck back in the 1950s, so I wouldn't pay much attention there. Okay, I think we got maybe one more question in me here. Maybe two. Do I correctly recall that you once mentioned a type of lumbar injection to help discriminate whether OTC symptoms of abnormal EMGs were due to another cause? Yeah, Charmaine, I think what you're talking about there is a simple caudal epidural of platelet lysate. So we see a lot of sacral radiculopathy, meaning pissed off sacral nerves that cause problems with, cause urinary symptoms, especially in women with low back pain. And regrettably, I think what we've seen with the rise of occult tethered cord diagnoses and occult tethered cord release is a whole group of patients who are getting tethered cord releases who really just needed a caudal epidural, but the doctor is offering the tethered cord releases don't really have that skill set and have never really done that. So yeah, I think for many of those patients, they respond quite well to a caudal epidural because they'd have just common sacral nerve root irritation, which is very common in women with low back pain. Okay, let's see. DO student elective rotation our clinic. Absolutely happy to have you. Just go ahead and reach out to me via email at that email address I put up there. AI will have doctors on unemployment too. Yeah, Robert, I think so. Thankfully, I will be retired at that point. And I also think it's probably going to take a generation of people who grow up walking to planes without pilots, which will happen as well, and walking to cars without drivers to really embrace going to a non-human doctor or really just getting diagnosed by their phone. But we're already seeing that behavior change, right? We're seeing people use ChatGPT to get a medical diagnosis. Problem in CCI is there's so little information out there. ChatGPT doesn't know which end is up because it hasn't been trained on a large firm data set about what's real and what's not. But in most medical diagnoses, it works pretty well, especially at GPT-5. Now, I think it'll take, like I said, a generation that grows up in planes without pilots and cars without drivers to lay down and let an Android surgeon do a procedure like this. So then maybe that's 20 plus years out, but I think the ability to do it is 10 years out. And then there's going to be all sorts of societal things that happen, regulatory things, medical licensing, et cetera, et cetera, et cetera. That will slow its adoption down, but it is a foregone conclusion, in my opinion, at this point. Okay, I think, guys, I am just selecting interesting questions here. Does the patient's baseline level of inflammation affect how they respond to injections or affect which ones you select? Yes, if that patient is centrally sensitized, then the answer to that is yes. Part of that sensitization can certainly be inflammatory, and we use someone's past response, and many times that's an inflammatory response, to gauge how we're going to treat them going forward all the time. Okay, guys, I got a bunch of questions here that keep coming, but I got to move on with my day. Lindsay, the 5th generation mouthpiece made a huge difference for my first ePICL and my recovery. Thank you, Dr. C. Yeah, we're seeing that across the board, Lindsay. The 5th generation mouthpiece is just a game changer. The 4th generation was a good one because it got us to the point of stability, meaning that you could routinely do good procedures, but it failed at the margins. And the difficult patients in the margins, it wasn't able to handle those. The 5th generation mouthpiece addresses those margins and makes the midsection even much better. So couldn't be happier with how that has changed things. It's reducing procedure times, which reduces anesthesia times. It's facilitating a much quicker, more precise procedure, which improves outcomes and also reduces flare-ups. So it's been a game changer. I want to thank Ryder, my assistant, for taking some time. I started the whole thing, but Ryder was able to help get it going, and I appreciate him for that. And I want to thank the biomedical engineer we were working with, because I think he was great. We've worked with several biomedical engineers, and we've had good ones, we've had mediocre ones, and we've had bad ones. This guy was a really good one. Okay, guys, I think that's it. Thank you, Julie. So I want to thank everyone for watching, for spending their Sunday morning with me. I'm going to move on with my Sunday here. Hear my wife coming home. I will be here next weekend doing some other interesting topic and answering questions. Hope everyone has a great day and a great weekend and a great week. Thank you.